Oh my God, beta thalassemia part 2. In this one, I shall be leading with the laboratory picture of it. The peripheral blood smear first. What I see is the pale as well as the small RBCs, microcytic hypochromic RBCs. Again, I find that there is a thin rim of hemoglobinization as we had seen in a case of iron deficiency. However, in a good number of cells, there will be a central hemoglobinization called the target cells. These are being produced. Teardrop cells can also be seen. Sometimes, very rarely, there can be a combination of sickle cell and thalassemia. Before I go to the next one, this is a test called the Nestrov test. And it is a control, and this is the thalassemia patient sample. In a control, I am able to find that I can read the letters behind the test sample. Whereas in the actual patient of thalassemia, there is turbimetry and it obscures the letters or a line. This is called as Nestrov's test. This you people shall by heart. The hemoglobin is markedly reduced, 9 to as low as 3 grams. PCV is also accordingly reduced, packed cell volume. RBC is microcytic hypochromic. And there will be a good number of target cells. Basophilic stippling is one of the classical features. Inclusions such as Hall Jolly bodies will be present. Normoblasts are present because of the increased destruction of the RBCs. Polychromatic cells or the reticulocyte count is increased, can vary from 5 to 10%. The granular cytoplasmic inclusions represent the aggregation of the alpha chains because the beta chains are defective. And they can be demonstrated by methyl violet staining. Punctate basophilia is again a feature. Any one of these can be asked as an MCQ, therefore please memorize them. WBCs and platelets are not affected. One of the tests that can be done can be the hemoglobin electrophoresis. In this case, courtesy Labpedia, I find normally there is a decreased amount of hemoglobin F, but in a patient with a thalassemia, you find that there can be an increased amount of hemoglobin F, compensating for the defect in hemoglobin A. This is shown by electrophoresis. This picture we had already seen in iron deficiency anemia. Again, memorize. So you have got the serum ferritin, serum iron, iron binding capacity, transferrin, tissue iron stores. And the picture will be exactly opposite of iron deficiency anemia. Serum ferritin is decreased here, it is increased. Serum iron is decreased, it is increased. Iron binding capacity is increased in iron deficiency, whereas here it can be normal or decreased. Transferrin saturation is again increased. Tissue iron stores are increased because of hemochromatosis or hemocytosis. Please by heart this table. So this is the pathogenesis. You people can draw this. There is the beta globin and the alpha globin genes. They will be producing the beta globin protein and the alpha globin protein. Normally they are in pairs and there is no precipitation. But when one is defective, you find that the other can get precipitated. Free alpha globin is produced and that can lead to phagocytosis, or there can be increased amount of reactive oxygen species, a part of phagocytosis, hemolysis and ineffective erythropoiesis. All of this can lead to an anemia. A very simple line diagram which you people shall and will draw. The bone marrow examination, I told you. There is an expansion which will be showing a crew-cut appearance or a mongoloid faces. Cellularity is increased, hypercellular because of compensation. Ring sideroblast may be present. The treatment will be repeated transfusion, chelating agents, splenectomy after age of 6 years to compensate for infections, and treatment for cardiac failure or the other thing. Bone marrow transplantation is the ultimate one. Life expectancy is markedly reduced. The defect can be occurring at these levels. The molecular basis of it. So there is the gene that is here, it has got exon, intron. There will be 3 of the exons and 2 of the introns, and by the side you have got 3 dash and 5 dash. Now, whenever there is a defect or a mutation, you get an abnormal gene that is being produced. So, the defect can happen in any of these. That is shown in the next picture also. Look at this, a beautiful picture from Britannia. So, it is a gene that is good. Normally, you find that the introns are being sequentially removed and the exons alone fuse, and ultimately you get the exon, and that is being converted by messenger RNA, and it is a process called translation. You get a normal amino acid or protein. But in a case of thalassemia, there can be a defect or a mutation in the exon, mutation in the intron, mutation at the intron-exon junction, etc. As a result of which you will be having, see this one. The intron is supposed to disappear, but it persists. Therefore, it is abnormal. Here again, the exon 2 should also be here, but since it is abnormal, it disappears and there is only exon 1 and 3. So, either of these cases are defective. Courtesy, National Cancer Institute, Wikipedia. These defects have been mentioned. I would like you people to kindly go through it. We shall go to the next class.